Hello, my name is Ruben Mesa, and I'm the director of the Mays Cancer Center at UT Health San Antonio MD Anderson. And I'm joined by my fellow colleague here at our center and fellow MPN focused clinician investigator, Dr. Robin Sherber. Welcome, Robin.
Oh, well, it's great to be here again.
So this video is one in a series that we like to produce regarding updates regarding myeloproliferative neoplasms. And there are many exciting things to share with you as we update the information both coming out now in 2019 as well as from recent congresses in both Europe and in the US regarding hematologic malignancies as well as myeloproliferative neoplasms. So first, let's cover with several of the areas that Dr. Sherber and I have had a strong area of focus in, which is regarding symptoms and quality of life with patients with myeloproliferative neoplasms. There were a few key things that you've presented this summer, Robin, including issues in collaboration with our colleagues from Denmark. Why don't you share those with the audience?
Great. Well, we looked at the association between basically body mass index, which is a calculation based on weight and height, so kind of generally what someone's physique is, and symptom burden. What we were able to see is that patients with very, very high or very, very low body mass index tended to have higher symptoms, and people right around kind of the middle ground had the lowest rate of symptom burden. So this suggests that maybe altering what we eat and how we exercise and our general body composition might actually have a way to impact symptoms.
Excellent. Now, you're also actively investigating, and congratulations on your first grant for helping patients with MPNs regarding impact of potentially diet and certain types of diet on MPNs and MPN symptoms. Why don't you share that with them?
Yeah, I'm very excited. So have recently got a grant that looks at a different type of a diet, specifically nutritional ketosis, or where you're trying to eat very low sugars or carbohydrates, and what the impact of that might be on blood counts, as well as on symptom burden, and generally how the MPN disease course does.
Great. So we're hopeful that by perhaps changes in the diet, we might end up seeing improvements in inflammation and potentially improvements in symptoms. So this is part of a theme of efforts that Dr. Sherber is working on, as well as other collaborators such as Dr. Huberty and others, as we're looking at impact of diet, as we're looking at impact of meditation through randomized studies with the Calm app, as we're looking at yoga, and other ways that MPN patients may be able to feel better, even while being on stable medical therapy. We're also collaborating very extensively with the MPN Research Foundation. We're playing part of a larger team that has developed a registry study called MyMPN. Robin, why don't you tell them a bit about MyMPN and where they may be able to sign up for this?
Great. Well, MyMPN is an online registry for patients with MPNs, so essential thrombocythemia, polycythemia vera, myelofibrosis. And the MyMPN registry is intended to be able to understand more about the overall disease course. So patients can go online, they can get an assessment of symptom burden. We ask them about different features related to their disease, so whether or not they've had a history of phlebotomies or if they've had different bone marrow biopsies. And the registry allows people in the registry to track things over time, including symptoms or other disease-related events. Some of the exciting data that we just shared at EHA, the European Hematology Association recently, was the association in the registry between different molecular mutations or changes in the DNA and symptom burden. And we were able to see that patients with JAK2 mutations or with MPL mutations had a higher symptom burden than those with calreticulin mutations.
So learn more about that on the MPN Research Foundation website, where you will find a link for participating with that registry if you're not already doing so. Now, many updates as it relates to new therapies for MPNs, and something that I know is of tremendous interest to all of those watching this video. First, let's highlight some of the new information and upcoming changes with the 3 active JAK inhibitors that are being tested in parallel with the currently approved therapy of Ruxolitinib. The first of those agents I'd highlight is fedratinib. Fedratinib is also a JAK2 inhibitor. And at this summer, we presented an updated analysis of a prior study. Fedratinib had a upfront study versus placebo in patients from frontline with myelofibrosis that showed improvement in splenomegaly and symptoms. Now, that drug had a period of time where it was held as there was deeper investigation in a low rate of side effects, neurologic side effects in about 1% of the patients. That process has been resolved and is being looked at in a new prospective study. What we presented this study was the updated analysis of the Jakarta-2 study. This was the use of fedratinib in patients that had previously failed ruxolitinib. I did this along with Dr. Claire Harrison and many co-investigators. What this analysis did was, using more modern criteria than we had used at that time, we used a stringent set of criteria for defining what was ruxolitinib failure. We only looked at patients that had been adequately treated with ruxolitinib to really evaluate the therapy, and then patients that had an adequate trial of fedratinib. With that, we identified that a third or more of patients that had clearly failed ruxolitinib with fairly stringent criteria benefited from fedratinib. This and other information is currently being reviewed by the FDA in terms of seeing whether fedratinib should become approved, and if so, for which patients. In parallel with this, momelotinib, a JAK2 inhibitor that previously had shown benefit in improving anemia and thrombocytopenia, had previously been tested against ruxolitinib as frontline therapy. There are now upcoming studies that will be looking at momelotinib in patients that have failed ruxolitinib in the past, and those studies should be upcoming for people to potentially enroll in the future. The third drug is pacritinib. Robin, want to give them a little bit of an update and reminder what pacritinib is and where it may be tested?
Sure. So similar to momelotinib and our other JAK inhibitors, pacritinib specifically is being looked at in the setting of low platelets. So they have the other studies that have been continuing to be ongoing in terms of analysis, but they're actually looking at starting up a new study that will be specifically targeted to patients with low platelets, or generally kind of have a less proliferative blood counts. But it should be exciting to watch the development of all of these JAK inhibitors.
Well, great. So our currently main approved therapy for myelofibrosis remains ruxolitinib. And now approved over 8 years, we have come to learn many things about that. Updates from this summer include a variety of different combination studies that have shown some promise. Prior combination studies have shown some benefit, including a study which I led with colleagues, which included ruxolitinib with danazol in aiding patients both for splenomegaly and symptoms, but also anemia with the danazol. But there's some new combination studies that have been reported recently. Robin, why don't you share a few details of those with them?
Back in December, we heard some exciting updates on the combination of ruxolitinib with another agent called lenalidomide. And in those patients, there seemed to be significant improvement in platelets or thrombocytopenia. The second combination looked at ruxolitinib plus another drug called pomalidomide that's very similar to lenalidomide. And in this setting, they saw some improvements in anemia and again, some improvements in thrombocytopenia. But what's exciting about both of those agents is that, especially for lenalidomide and for thalidomide, we potentially have the ability to use that what we call open label, or we can prescribe it because it's already FDA approved in other settings.
Now, there have been some recently published reports that had a concern whether patients on ruxolitinib might have a slight increased risk of lymphoma or other cancers such as skin cancers. First, anything more we've learned about this question with lymphoma?
Yes, so some of our good colleagues at MD Anderson main site in Houston did an analysis of their patient population, and they saw no increased risk of lymphoma on patients receiving ruxolitinib. It was also exciting at this European Hematology Association conference. There were 2 other studies that looked at their specific patient population, again, to see if they could see an association between using ruxolitinib and the risk of lymphomas, and they didn't see an increased risk.
Excellent. Well, very, very reassuring. We have seen, and there's now on the label, a slight increased risk of non-melanoma skin cancer in patients that have been treated with ruxolitinib. Now, it's difficult to know the independent contribution of the medication. In part, many of these patients have previously received hydroxyurea, which is known to increase the risk of non-melanoma skin cancers. Second, we know from population-based studies that there's a higher rate of non-melanoma skin cancers in patients with MPNs independent of therapy. But it is certainly something to be mindful of. And I think this being the summer, all patients with MPNs should be mindful of using good sunscreens and certainly have good dermatologic care, in that that's an increased risk probably for many of us, but in particular those that have MPNs. Now, an agent of tremendous interest is interferons, and particularly the long-acting interferons. We presented updates at the ASH 2018 meeting regarding the upfront study of Pegylated interferon alpha 2A versus hydroxyurea in patients with ET and PV, where benefit was seen with the Pegylated interferon as well as with the hydrea. One could say that they were equivalent, but both equally effective, and they had a variable impact on symptoms. We also learned this summer of updates regarding Pegylated interferon, a drug that comes out of Taiwan and Austria, in an upfront study in patients with high-risk PV who were randomized between Pegylated interferon versus hydroxyurea. Robin, what were those updates and what impact might that have on approval in Europe?
Well, we were able to see that Peg interferon did a great job of helping to control blood counts, which we were hoping would happen. We had seen in earlier studies. We also saw that there are some evidence of molecular responses where people are seeing the amount of mutations in the blood go down. So all of that's very exciting, and that's led the European Union to start to consider Peg on the path to potential drug approval.
So it's very exciting news. So what that means specifically for MPN patients is, first, it's not approved in Europe yet, but likely will be in the near future. Approval in the US is separate, but certainly is informed by the experience in Europe, and there may be an approval in the US in the future. There may be additional data that needs to be gathered for that to be present and such. But it'll be something that we'll be watching very carefully, as well as sharing with you as more is known and through various MPN educational outlets, including MPN Advocacy, the MPN Research Foundation, and certainly our website. Now, finally, there are many new drugs that are investigational that we'll highlight as well. One class of them include agents that may potentially help to improve anemia. First of these was discussed at the EHA meeting, sotatercept. Robin, updates on this medication and the outcomes they saw?
Sure. So they looked at sotatercept in a particularly difficult setting. So in myelofibrosis patients who really hadn't had much of a ruxolitinib response or had lost response. And in that setting, they were able to see that there was significant improvements in anemia. And that's a particularly challenging setting for them, just because that ruxolitinib can actually worsen anemia. So very exciting. That's continuing to be going on in terms of research.
Excellent. And there is a cousin drug owned by the same company called luspatercept. And that agent has been in a trial that I have been involved with of luspatercept alone or in combination in patients with ruxolitinib to try to improve anemia. That study remains ongoing. We're preliminarily seeing some favorable results with that. And we'll be sharing more as that is identified, perhaps more at this 2019 upcoming American Society of Hematology meeting. Next, the MPN Research Consortium is actively looking at a range of trials, scientifically based, for new ways to tackle myelofibrosis, in particular in patients that have failed ruxolitinib. That consortium is funded by the National Cancer Institute, led by my colleague, Dr. Ron Hoffman. I, John Mascarenas, and many others are co-investigators. We have the first of these studies that are opening at our center and other MPN Research Consortium centers. Robin, why don't you tell them a bit about that study?
Great. Well, the Abid 200 drug is being investigated in patients, again, who may not have had a very good response to ruxolitinib or for whatever reason can't be dosed fully. But this drug is a TGF-beta inhibitor. And so basically what that means is that it helps to inhibit one of the key pathways that they found that it contributes to bone marrow fibrosis. So the hope with this is that this TGF-beta inhibitor might reduce bone marrow fibrosis.
Excellent. At EHA, we heard a bit of an update on some positive results with a BET inhibitor from, I believe, Constellation Pharmaceuticals. Why don't you tell us a bit about that?
Great. Well, in the Manifest trial, they looked at that BET inhibitor. The other name is CPI 0610. And they have an ongoing study looking at this in 3 different settings. They're looking at it basically in patients who have already had ruxolitinib but might have lost response or had progression. They're also looking at it in combination with ruxolitinib in those that may not have an optimal response. And then in a third line, in those actually frontline, so before they've had ruxolitinib. In their early analysis of the study that they have so far, they've shown basically some improvement in symptom burden that looked very promising. They've shown improvement in anemia, and in a few patients, improvement in bone marrow fibrosis.
Great. And then finally, let's talk about the results with the LSD1 inhibitor, both the data presented with myelofibrosis, and you can foreshadow our upcoming ET study that you're leading.
Well, it's exciting data here as well. LSD1 inhibitor, it's also called IMG 7289. Specifically, it targets the growth of the cells that make platelets called megakaryocytes. But what's also exciting is it also can help reduce inflammation. So they're looking at this to potentially help reduce bone marrow fibrosis, which there were some early signals that it does, as well as to potentially help with symptom burden and reduce spleen size in patients who, again, may not have had an optimal response or who have, for whatever reason, are not able to tolerate or had progression on ruxolitinib. Exciting to us is we will be opening with this drug a trial in essential thrombocythemia, looking at how this drug decreases platelets and helps to control blood counts, as well as helps to control symptom burden.
Well, great. Well, hopefully we've conveyed a sense of excitement regarding many of the interesting things going on to really help advance the resources for MPN patients, both in new therapeutic drug trials as well as non-pharmacologic studies, really to help alleviate the symptoms and difficulties that patients face. Indeed, at our center each and every day, we now have trials available for patients with ET, myelofibrosis, even a new study in PV for patients who are receiving phlebotomies for PV that might be helpful. So a lot of exciting things ongoing, much to be hopeful for. Robin, give them perhaps a takeaway in terms of things that you're looking forward to this next year about us further learning about MPNs?
Well, I think that overall we're making progress. We're finding therapies that not only help to improve anemia and thrombocytopenia, but help to improve symptom burden, and as always, the goal to potentially find a cure.
Indeed, many exciting things going on that are in the future, including immune-based therapies, cellular-based therapies, potential vaccines against calreticulin, or even gene editing is being discussed using either zinc finger approaches or CRISPR. So much more to come in the future. Again, please make use of both our website, and we will continue to be providing these videos as a resource for MPN patients. Thank you.
Thank you.